You're welcome to today's journal club and journal club meeting. We're going to talk about how to quickly appraise randomized control trial study. So we're going to do this in two parts, and I'll take the first part, maybe the first 30 minutes, to talk about how to critique a randomized control trial, while Zai would go through to talk about the second part. We already have a paper that we're going to use to practice what we're going to talk about in the first part. So Zai will handle that part. So why critical appraisal of studies? Why do we want to appraise studies? One of the reasons is that it helps to assess the validity, reliability, and relevance of research findings, and ensures that studies are methodologically sound and worthy of consideration. So we want to be sure that studies that we're going to be using for whatever reason is a sound study, just not any study that we picked on the road. And it also helps healthcare workers, professionals, and policymakers, as well as researchers, to make informed decisions about adopting new treatments, guidelines, or policy. So if you're going to do anything with respect to interventions, you will need to have evidence of what is already being done somewhere else or close by. And you need to do a critical appraisal of those evidence to be sure that they are quality evidence to enhance your decision. It also helps in identification of best practices and to help in identifying gaps in research and areas for further investigation. So ultimately, contributing to evidence-based practice and improved outcomes. So what this essentially means is that we are constantly doing research and we are constantly looking for gaps where we can improve on. So this really would help for you to identify gaps when you're doing your literature review. You're not just picking papers for picking sake. You're going through them systematically and methodologically to be sure that papers that you're using for your research has the quality that you want. So regarding any critical appraisal you're going to be doing, the ones we do like in this our journal club, there are things you need to note. I adapted this slide from the CAPS to the checklist for doing critical appraisal. So one of the things you need to do is to note your name as the reviewer, the title of the paper, the author, the web link, and the appraisal date. For instance, Zai will be doing the review for us for the paper, so her name would be there, and the title of the RCT we are doing, the authors or the author, the DOI, and the appraisal date, which is today, 7th of December, 2024. So you need to have that and write them down. Then coming to RCTs, there are broad areas of what you need to do. If you recall what we said at the beginning, why do we do critical appraisal? Is for us to be able to inform decision, assess methodological quality, and also to find gaps. So for critical appraisal of randomized control trials, we're going to be looking at four broad areas to be sure that we are in the right track. So the first thing you need to ask yourself is the basic study design valid for a randomized control trial? So if you're reading a paper, you should ask them, are they using the right sort of this study design? Is its RCT fit for this? Or should we have used a different type of study design? And the second thing you find after addressing that, and you have convinced yourself that an RCT is the right thing to use, you would have to move on to check whether the study is methodologically sound. Have they done the right things they're supposed to do method-wise? So we would look at the various things you might need to consider while doing that. So the next thing to talk about is if they have done the right things they're supposed to do in terms of their methodology. What are the results? What did they find out? Their primary outcomes, secondary outcomes. What are the effect size? Have they done the right things they're supposed to do? We'll consider those briefly in this our short meeting. So the next thing you need to consider is, will the result help locally? Most times, studies done somewhere else might not be relevant to your local population. So you need to be sure that if you're given a paper to review and appraise, you should be confident to say this paper can be transferred, or the learnings from this paper can be transported into my own locality. If not, the paper might still be methodologically sound, but not useful for your population or for the demography of your patients or your service users. So going to the first section, we talked about, is the basic study design valid for a randomized controlled trial? There are things we're going to be looking at. The first thing is, did the study address a clearly formulated research question? Usually, you have box 6 where you take yes, no, or can't tell. So you should be able to convince yourself and say, I'm convinced that this is a yes or a no or can't tell. Don't assume anything about what the researchers have done. If you're not sure, you need to say can't tell. So, did the study address a clearly formulated research question? What are the things you're going to be thinking about when you talk about research questions? One of the things you need to consider is, was the study designed to assess the outcome of an intervention? So, you're looking at a framework. Usually they talk about the PICO framework, the population, the intervention, the comparators, and the outcome. So is the population of that is being studied discussed? For instance, they may be talking about a population of elderly people living in care home in a particular geography or location. So they've talked about the population, or maybe on the fives, if they are interested in studying about maybe uptake or acceptability of a certain vaccine that is being introduced. So is the population discussed? Have they talked about the intervention? And if you're doing a randomized controlled trial, remember, if you can turn off your microphone, that would be great. Thank you very much, to avoid interference. So you need to have comparison or comparators when you're doing a randomized control trial, because you're actually doing an experiment and you're saying group A and group B, I'm going to introduce something, maybe an intervention, a drug or anything, to one of the groups, and I will not do it to the other group to check if the intervention I'm introducing is going to work or might improve health outcomes. So have they chosen a comparator, and have they also measured the outcome? The outcome you're measuring may be reduction in blood pressure, as you may see in the paper that we reviewed. So these are things you consider in research question formulation. The popular one I've mentioned is the use of PICO framework: population, intervention, comparators, and outcome. If it is there, so you will tick yes, but if not, it might be no. And if you're not sure, it's I can't tell. So was the assignment of participants to interventions randomized? Still yes, no, can't tell. So you will have to ask yourself, what is randomization? When you're trying to group the subjects into control and the experimental group, you need to select them in such a way that you don't have any influence. Allocation is not with your influence, so it's randomized. So it might be in terms of you're using a random generator of codes. So it might be that code is computer generated. If you have selected your sample, say you've got 100 people to randomize into two groups, a specific code is being generated by a computer that you're not in charge of to assign people into different groups. So you need to know whether a randomization has been done, how was it done, and was it enough to eliminate systematic bias. So we're trying to remove bias when we are doing this randomization and remove confounding effects. So you don't want particular characteristics of your subjects to be responsible. Did someone say anything? I can see same here. Are people hearing me at all? Okay, you can
Yes.
hear me. Okay, so I will
Yes,
continue. Sorry, I will continue. So, was randomization sufficient for systematic bias? So you don't want your patient characteristics or your population, the group you've selected, their characteristics to be responsible or to influence the outcome you're interested in. For instance, if you're trying to randomize, you're trying to group two groups into intervention and control, and in one group, all of them are over 60 years, and in the other group, all of them are like under 40, you are likely to find out that your results will be biased because of that age. So if you're looking for maybe high blood pressure, you tend to get it above that age, and so you need to randomize it such that that age effect, which is more like a confounder, is removed by that randomization. And you will need to also check whether the allocation sequence was concealed from investigators and participants. So how it's just the thing I've explained, you're not in control of how patients or participants are allocated to each group, so that maybe we are trialing a new drug to cure a certain rare disease or something like that, and I don't want my friend to be part of the group that it's being tried, because I don't know the side effects of the drug and all that. So because I'm a human being, if I'm aware, I might now want to put maybe my friend on the placebo end, where I'm more certain that no, nothing will happen to him. So you do it in such a way that nobody is having any privilege. Everybody is randomized equally. There's equal chance of being in any group. So the next thing you consider is were all participants who entered the study accounted for at its conclusion. So these are some of the things you need to look out for in randomized control trial. You start with a baseline and follow them up depending on the length of the study and the availability of the resources. Some studies could be up to 1 year, 6 months, or even more. So you would have to account for what you started from the beginning and the end. And there's a term called loss to follow up and exclusions after randomization. So it's possible that people start the treatment, maybe the new treatment, and they are not finding it very okay. They are having some adverse symptoms that they don't want, and they just drop it. And you find out in real life it happens most times when your clinician gives you medicine to take it for 1 or 2 days and drop, you don't continue. So sometimes people drop, people even swap group. For instance, if I'm doing a research and I'm a participant with my friend, and my friend is on the opposite side, and I find out, it's possible that one can swap without really telling the researchers. So that's why you try as much as possible to do what is called blinding, or we'll get to that point. So where participants analyzed in study groups to which they were randomized. So this is called intention to treat analysis. It's just something I've talked about just a moment ago. People can switch, people can stop taking what they have been asked to take because they're not feeling very okay with the side effects and stuff like that. So, but in analysis of RCTs, you try to do intention to treat analysis. So analyze as randomized. So because that is exactly the same thing in human nature. So people are not robots. They try to change. So as you have randomized them at the beginning, that's how you would analyze them at the end. So you wouldn't say because Mr. A swapped to B, you now move the number of Mr. A to B. So that's the simple interpretation of what intention to treat means. And sometimes in RCTs, a lot of care is taken so that people don't have very severe adverse effects. So there are data and safety monitoring, independent data and safety monitoring group who will be monitoring and checking things over time to be sure that people's lives are not in danger because of your research. So this question is, was the study stopped early? If so, what was the reason? So you need to find out. We would show the practicals when Zai takes over from me. So we move on. You've satisfied yourself that the basic study design is randomized controlled trial. Then the next thing you have to do is to check whether the study is methodologically sound. Is this study sound at all? Is it the right? Have they done the right things they're supposed to do, the right measurements and things like that? So that's what we'll move on. So one very key thing you need to take note of is blinding. So you don't blinding is, let me try to simplify it. It means making the participants, the assessors, the researchers unaware of who takes the intervention or who takes the placebo. That is called blinding. The reason is because you don't want awareness of what one is taking to affect their response. For instance, if I'm aware that if a subject is aware that they are in the intervention group, they are likely to maybe behave differently or say things differently because of that awareness. So you should ask yourself, were the participants blind to the intervention they were giving? Were the investigators blind to the interventions they were giving to participants? And were the assessors and analysts blinded as well? So these are some of the things. A researcher can interfere if they are aware of who takes what. I already gave an example prior to this time. Even the investigator, maybe if he's a clinician and they are aware of the patient's condition, it might make them decide to do a different thing. It might be well intended, really, because they might think that, okay, this patient is not well enough to be in this group or in this category. So that is what blinding helps us. So any of those bias that will be introduced through blinding, through patients, assessors, or investigators being aware of what is being given, you can mitigate that through blinding. And I would also say here that sometimes it may not be possible to blind the intervention, as we may see in the study we did. So I'm not going ahead of myself. Okay, so the next thing you ask, were the study groups similar at the start of the randomization? So when you start your study, I've talked about randomizing them using maybe a computer-generated numbers to separate the intervention and the control group. But you also still have to check whether their characteristics are the same. So, for instance, are they equal number of men and women on the both sides? What's the mean age on the both sides? So you need to be sure that there is no significant difference between them, because that is how you will assure yourself that those factors will not become the independent contributor to what is going on instead of your intervention. So that's what we call the confounding effect. So you need to assure yourself that it's a yes or a no, or you can't tell. You also need to find out that apart from the experimental intervention, did each study group receive the same level of care? That is, were they treated equally? So ethically, you cannot withhold treatment from anybody because you're doing an experiment. So if someone is supposed to be on a particular medicine, you need to give that person that medicine, even if the person is joining in your intervention. So you will not withdraw that. And you also need to treat everybody equally, except that intervention you're interested in, because the case you want to make is that it is the intervention I'm introducing that is responsible for the effects that I have seen over 6 months or over 1 year of follow-up. So also, you need to be sure that there has been a defined study protocol. There is something they call publication bias, where people tend not to publish their data because they didn't get the expected outcome or effect size, or there was no statistical significance, so they don't publish those data. And because of that, there's been a move to encourage people to, before you start your RCT, your experiments, you need to write the protocol and also publish it, so that people are encouraged to publish it. Because at the end, when you gather RCTs together and do what we call systematic review, you'll be able to find out all the available evidence supporting that intervention, and you can make a quality decision. So, but if some studies are not published because they didn't give us the expected results, so we'll be having some publication bias. So you need to be sure that the study was clearly, the study protocol was defined and published. So if any additional interventions were given, what were they? Was it the same or different? You just want to be sure that everything is on the same side, apart from that intervention. Were the follow-up intervals the same for each study? So if you're going to measure things after 6 months, it has to be 6 months for it, 6 months for the intervention and the control group. 1 year, 1 year. So you don't do 5 months in one group and do 6 months in the other one, just for instance. So these are things you look out for in your study. There were a number of things that we haven't talked about. So if you are going to do measurements, you need to be sure that your measurements equipment are calibrated and they are valid and reliable. So validity and reliability, they are separate things terms you need to know. And you need to be sure that they are devoid of errors. Errors could be observer error, it could be instrument error. So if the instrument is not well calibrated or the calibrations have worn out, it can introduce error. If the people who are supposed to do the measurements, if they are different people and there is no standardized training for them, there can be inter-observer error. So those are things you need to be sure. And when you're reading a trial, you're checking, have they measured the things they are supposed to measure? Who measured it? Was there a quality control training for the people who have measured them? So those are things you need to be thinking about. If those have not been done, then you can say that maybe the study would have had some issues. Then we move on to the next thing. What are the results? So what results are you looking at? Are you looking at the primary and the secondary results? But before you even move on to look at the results, so you need to think about sample size calculation and the power of the study that will give you adequate sample to make inference. So maybe in subsequent discussions, we'll try and break down what some of these things mean. Sample size determination, sampling methods, how to calculate power, all those sort of things. But these are things you need to arm yourself. Did they get the enough sample size that would help us make inference to the population that this is what is happening? Because it's not possible to randomize the whole population of your study participants. So you need to sample from them. And how you do that, it involves calculation of power. So what outcomes are measured and were they clearly specified? So from the word go, you need to know what you're going to be measuring. So if I'm introducing a drug to reduce blood pressure, what am I going to be measuring? Am I measuring systolic blood pressure or diastolic blood pressure? Are there other things? If I'm introducing a medicine for control of diabetes, am I looking at random blood sugar? Am I looking at HbA1c after a while? So those are some of the things. Have they clarified things they're going to be measuring? Which ones are primary? Which ones are secondary outcomes? And were the result expressed? How was the result expressed? Were they expressed as binary outcomes, or were they relative and absolute effects reported? So it could be a yes or no. That's sort of binary outcome. It could be they are just talking about differences in mean, or anything else. So what is the effect size they are looking at, and how are they measuring it? Was there any missing or incomplete data? Usually you may have some missing data when people don't complete their follow-up, when they are lost to follow-up, there might be missing data, and what was done about those. You also need to think about if there is loss to follow-up, like we mentioned, people can die along the line, people can decide they don't want to continue. So those are losses to follow-up. So you need to check, is there a difference in loss to follow-up between the intervention and the control group? If there is a difference, you would be worried because it might affect the outcome you get. So what are the potential bias that have been identified? So there are a lot of systematic differences in the control and intervention that can affect the result you've got. It could be how it was measured, so measurement bias. It could be information bias, record bias. All those, there are a lot of bias in research. So we might also pick up some of those things and discuss at a later time. What is a bias? How do we identify them? How can we control for bias from the beginning of the research? So which statistical texts were used? Did they use chi-square? Did they use whatever t-test? Did they do regression to adjust for confounders? All those sort of things. And did they express their values in p-value? Or did they also check the precision of their results using confidence interval? So these are some of the things you need to check if they have done that. So I've gone ahead to talk about the precision of the estimates or the effect size they've got using confidence intervals. So usually most studies will use 95% confidence interval, which just means that we are 95% sure that the result we are getting is something we can get in the total population. So that's what maybe the late definition of 195% interval means. So it gives you the precision of how precise your result is and how you can infer it to your general population. You also need to ask yourself whether the benefits of the intervention outweighs the harms and the costs. For every intervention, there is a benefit, there is a harm. So have you calculated those the benefits? What is the harm to people? So if you're trying to control something and inadvertently you're causing more harm, that experiment needs to stop. Also, there are a number of economic evaluation of interventions to be sure that you're not wasting scarce resources on interventions. So we would do economic evaluation at a later stage in our club. So if you keep coming, some of these terms we're mentioning will become very familiar to you. So if you don't know them now, don't worry a lot. We would go through all of them. But remember that we don't have all the money. The health system does not have all the money. So the same money, say for instance, you've got the Department of Treasury or Ministry of Finance, and they've got X amount of money for the budget of the year. So you have to justify that. You have to justify why the money that should be given to you through economic evaluation. So there are things like cost-effective analysis, there is cost utility analysis, cost minimization analysis, cost consequences analysis, a number of others, cost benefit analysis. Those are economic evaluation terms that we can break down in our subsequent discussion. So keep coming around and we will have ourselves enriched with those knowledge. Then we go to the last section, which is, will the result help locally? So your aim of reviewing a study would also tend towards what is in it for my patient, what is in it for my local people. So if you're a public health expert and you have a coverage of, your coverage region is such that the research you're looking at does not apply to them, no matter how good the research is, you wouldn't have to implement that because that would be wrong. For instance, if a study is done in somewhere in Europe, it might not necessarily be applicable or might not be the best thing to export to somewhere else in Africa. So that's why we need to arm ourselves with this knowledge, such that if there has been a study done elsewhere and your politician or your policy maker wants you to advise, usually it will be maybe you're working in the Ministry of Health or working in an NGO, wherever you're working as a researcher, and your politician or policy maker brings a paper for you to review. I have seen that this is a very good intervention. What do you think? Should we apply? Should we do what is in this paper? That's how it usually would go. So it's now left for you to go through the study systematically, critically appraising it to be sure that that study, even no matter how good it is, can also be applied in your locality. So these are the things I've already talked about. Are the study participants similar to the people in your care or in your environment? Would any differences between your population and study participants alter the outcomes reported in the study? So it's possible that maybe you're serving geriatric patients, elderly patients, and the study was done in young people and adolescents. There might be that temptation to export it, but age is a very important factor that you can't ignore. Are the outcomes important to your population? We've talked about it. Are there any outcomes you would have wanted information on that have not been studied or reported? Are there any limitations of the study that would affect your decision? So these are some of the things that you need to think about when you are doing your appraisal. It's not just for an academic purpose. You remember the first slide where we talked about why do we do critical appraisal, is to help decision, even though we can also use that to find gaps and also to appraise the methodology, the quality of methodology that was applied in the study. But also, very importantly, if you're working in the field, if you're working in outside the academia, you need to use that to inform decisions. So appraising papers is not just for the professors or people who lecture in the university or people who are research focused. It's also important for implementation scientists, because you need to be aware and convinced that the result you're getting is quality and it also relevant to your local population. So would the experimental intervention provide greater value to the people in your care than any of the existing interventions? Usually you would have different other things happening. On rare occasions, it might be the first time an experiment is being introduced, but most times it will be an improvement. Say you're looking at medicines for reduction of blood pressure. You would have seen that there are already existing medicines that can help in reducing blood pressure, but you're now saying that this other medicine would lower this other one, cause this, cause that, and make the patient better. That's the claim before the intervention. So you need to check whether this new medicine would help the people in any way. So there's this plane that's in health economics, they call it cost effectiveness plane. Actually, you check the effectiveness and the cost of what intervention that you're bringing in, and it will help you to decide, is this thing cost effective and can I use that? So if a shiny new intervention is not in any way improving the outcome of your patient or your population, no matter how shiny it is, you don't have to be bamboozled into taking that. For instance, you could see that maybe a new drug is being taken around. People are brandishing it like this is the newest drug and all that. As a doctor, nurse, clinician, whatever, health worker, public health expert, you don't need to jump into that if you have not critically reviewed the evidence behind that and assure yourself that this thing is qualitatively, the quality of the methodology is very good and it's applicable to my locality. The last thing you need to do is to list the key points from the critical appraisal that need to be considered when assessing the validity of the results and their usefulness in decision making. So you have your positive and your negative and your unknown. So we talked about yes, no, and I can't tell. So you combine all those, and that will help you to make a decision whether that study is of good quality or of poor quality. Thank you very much, and thank you for listening. If there are any questions, I can take one or two before we move on to the practicals. But if no question, I can just yield the floor straight to Zai to continue. So I just give 1 minute if anyone has any question. If none, then we'll move on. Okay, so I would imagine that the silence means no questions. Can people still hear me? I will stop sharing. Hello, can anybody hear me?
Yes, I can hear you.
Yes, thank you.
Okay, so I've stopped sharing and I will welcome Zai to take over.
All right, thank you, Kalu. I'm not sure if people are able to see my screen.
Yes, I can see
Whether
your
it's
screen.
in presentation or if is it in presentation mode or is it? Is it not in presentation mode?
I don't think it's actually longitudinal. Maybe that's your presentation mode. I don't know.
Yes, that's the presentation screen. If it's
Okay.
longitudinal, we're on the right track.
Okay.
All right. Before I start, I just want to check. I'm going to exit this because I can't really see other participants when I'm in here. But before I start, I just want to check if there's other people who already read the paper and managed to do part of the checklist or all of the checklist with the paper that was shared. Anyone?
I kind of read the paper too, so I can talk as well.
Okay. Anyone else? Okie dokie. All right. So that's going to be a little bit difficult. Sorry?
Said I read through, but I didn't use the checklist to go through the checklist.
Oh, excellent. Excellent. Is there anyone else who read the paper as well? Thanks, Emmanuel. All right. So I'm not sure how useful this will be for those that didn't read the paper, but I'm hoping maybe we'll get something from it. At any point, please do feel free to stop me. As I look at my screen, I want to be able to see what's going on in the chat box or anywhere. So just feel free to unmute and speak if there's something you want to interrupt me with. Okay, so this is a CASP checklist for randomized controlled trials. The first page, as was already introduced, is just name, title of the paper. For those who haven't read it, the link to the paper is in the journal club. So if you can quickly open it and scroll through as we're speaking. That way it makes more sense and it's not completely boring. All right, let's start with section A. First question, or the first section is the basic study design valid for an RCT? Question number 1, did the study address a clearly formulated research question? In this case, my answer was yes. The question, of course, we could use the PICO structure, which I use loosely here, but the question was, do poly pills prevent cardiovascular disease in non-white populations in the United States of America compared to usual care? So the patient population was non-white populations. The intervention was the poly pill. The comparator was usual care. And the outcome measured, the primary outcomes measured were systolic blood pressure and low density lipoprotein. Agreed? Disagreed? Even if you didn't read it, you can just give me morale by saying I agree.
I agree with you. Yeah, it was a yes.
Okay. Going on to the next one. Was the assignment of this just erase the yes, but was the assignment of participants to interventions randomized? So here, for me, the answer was actually can't tell. I wrote yes at the beginning because in the paper, they say that yes, but the actual process of randomization, the actual method was not reported. And they shared their protocol, but even in the protocol, the method of randomization was not reported, or I could not see it reported. I'm not sure if anyone else has a different opinion or if anyone else noted the same thing. And if you have the paper, honestly, just open it and just scroll through and see what you think.
Yeah, I think so too. They talked about randomizing it. They said open paper randomization or something like that. And I did see where they sort of said this is the randomization method we use. So it could be a yes, or it could be a cancel, depending on how you look at it. But they mentioned that they randomized.
Yeah. Because I put a yes as well until I read the consider part. That like, how was randomization carried out? Was the method appropriate? Was randomization sufficient to eliminate bias? Allocation sequence concealed? Like, that information was not given in the protocol. So that's what moved me from a yes to a can't tell, because those questions weren't answered in the protocol. Emmanuel, what do you think?
Sorry, like I said, I didn't go to the checklist to actually analyze it, but obviously participants were randomized, but to say is point in the checklist, I can't really comment on that because I didn't do
Okay.
analysis, but from quick view, probably say, yeah, the participants were randomized appropriately, but going to this checklist, one may have their opinion.
All right, thank you. All right, number 3, were all participants who entered the study accounted for at its conclusion? Yes. So the study or the results clearly detailed the losses to follow up, the exclusions after randomization, and the study wasn't stopped early anyway. And as for the intention to treat analysis, I'm actually not sure. I'm not even, like Kylie, you explained a little bit about that, but I'm not really very conversant with the intention to analysis thing. So I'm not sure about that, but I do know that they were all accounted for from beginning to end.
Yeah, they were not very unequivocal about adopting intention analysis, but they did a sort of sensitivity analysis to account for missing numbers or missing figures. So, and they did say that even though those differences or loss to follow up and missing information would have attenuated the effect size, but it wouldn't stop it from being significant.
Yeah. All right. Thank you for that, Kalu. So now moving on to section B, was the study methodologically sound? The first question under that section. Were participants blind to the intervention they were given? I think Kalu talked a bit about blinded trials. And this study was an open label trial. So everyone knew what the intervention was, who was in the intervention group, etc. So that does bring in a form of bias, but the participants were not blinded to the intervention. Investigators also not blinded. No one was blinded, essentially. So I'll skip on to number 5. Were the study groups similar at the start of the randomized control trial? And as Kalu explained, there are many confounds, especially in a study concerning cardiovascular disease. You do have to make sure that some baseline characteristics are shared somewhat evenly between the two groups. Otherwise, that does impact the results that are generated and your interpretation of those results. But in this study, the baseline characteristics were similar and they were reported. So they did try to control for confounders and for other demographics. Yes. I will assume yes until someone says no. All right, next. Okay. Next one. Apart from the experimental intervention, did each study receive the same level of care? That is, were they treated equally? So thinking about if there was a defined study protocol, which there was, as I mentioned, thinking about whether there were any extra tests or treatments given between the two groups. Because of course, if you're not giving the same amount of care to two groups, then it's hard to interpret the results as you've now introduced another confounder, which would be the care, the extra care that you're giving to whichever group. and follow-up intervals. So in this case, there was a clear enough study protocol. Both groups had the same follow-up intervals. And for both groups, the research staff, they were receiving clinical care from the research staff as well as from their own primary care physician. So there wasn't necessarily extra care given to either group, which was good. All right. Now moving on to the results. Were the effects of intervention reported comprehensively? Was the power calculation undertaken? What outcomes were measured, and were they clearly specified? So as we talked about before, the two primary outcomes that were measured were low-density lipoprotein and systolic blood pressure. And so the results were interpreted as essentially the differences in LDL and SPP from the beginning of the study to the end. So those differences were reported between the two groups with the p-values as well as with the confidence intervals. However, I don't know if we have to talk about, yes. So the results were expressed in the more absolute effect type of way. The results were reported for each outcome in each study group, but not at each follow-up interval. As for missing data, all missing data was accounted for. I think they mentioned that there was missing data for 2 people. However, apart from the missing data from the 2 people, there was a significant difference in the dropout rate between the study groups. So in the study group, in the intervention group, there was a much higher dropout rate. I think in the end, there was like over 20 people that dropped out in the intervention group, while there was less than 10 that dropped out in the control group or in the non-intervention group. So there was a significant dropout rate difference between the 2 groups, which should have impacted the data. Let's see what else here. Potential sources of bias were not necessarily identified in the paper. However, as we've discussed, it was an open label trial. So everyone knew what everyone was getting. So you can't eliminate that subconscious bias of knowing that this person is in the intervention group, etc. And as I just said, more dropouts in the intervention group. In terms of the statistical tests that were used, I don't think they were reported, but we did have the p-values reported. Okay, comments?
Yeah, can I come in just here? So they look at the main differences between the systolic blood pressure of the control and the intervention group, as well as the mean difference for the LDL, that's low density lipoprotein for the 2 groups, and check the did a t-test to actually check the difference and reported the value. So they did the p-value and as well the confidence interval, found that to be significant as well. So, and I think they also did some, they checked the second month and checked at the 12th month to see if there were differences. There was something else that they measured that was on adherence. Zai, if you can put off your microphone, it's interfering. When I finish, you can come up.
Sorry, let me do that.
Okay, so they also tried to look at adherence of that medication. The study was all about poly pill, using a number of drugs to control blood pressure. So we saw that they calculated adherence, and in that case found adherence to be around 80% or so. But how did they calculate adherence? By asking the people how many that they took, whether they took their medication the day before the test, or they came to see the doctor or the researcher, as well as counting the pills, which also have their own limitations. People can do whatever they want to do. And also, people can tell you that they took their medication, even if they did not take that medication, due to what we call social desirability bias. People won't tell you what you want to hear. So some of the things were measured, but it's not without its limitation. Sai, can you go ahead? I've also stopped seeing your video.
Let me go back to sharing the screen. It stopped. I'm not sure why it stopped sharing, but it did. So give me a second.
I can still see your screen.
Can you see it now?
Yes, I can see the screen.
Okay. Thank you. All right. Okay. Thank you, Carlo, for coming in there. Was the precision of the estimate of the intervention or treatment effect reported? Meaning the confidence intervals, they were reported for most of the findings. Okay. All right. And then, do the benefits of the experimental intervention outweigh the harms and costs? So from the results, it looks like there weren't a lot of serious adverse events, but the serious adverse events were non-cardiac and did not seem related to the polypill. Of course, I don't have a p-value for that not being related. However, the serious adverse events were a road accident, an overdose or something like that, of something else and something else. So they didn't seem related. Okay. And then here, was a cost effectiveness analysis undertaken? I don't think it was. Khalud, was it? I may have missed it, but I didn't see a cost effectiveness analysis.
No, I didn't see as well.
Yeah. All right. And then, will the results help locally? Can the results be applied to your local population or in your context? So to be fair, even when I started reading the paper, I had so many question marks because I found it interesting that they were developing an intervention to reduce cardiovascular disease in non-white or minority populations by coming up with a medication, when in actuality, a lot of the reason for the increase in cardiovascular disease is not necessarily biological, but because of socioeconomic inequalities and things related to socioeconomic status. So I found it interesting that this felt more of like, treating cancer with a Band-Aid and not really addressing the root cause of why there is a high rate of cardiovascular disease in minority populations, not just in the US, but in Europe in general. So for me, I found it absurd to create a pill to address this problem other than address the root causes that result in these populations having an increased risk for cardiovascular disease. My humble opinion. Carlo, Emmanuel, anyone else who is reading through, what do you think?
Yeah, I think they mentioned it as part of their limitations, so that, of course, there are wider determinants of health responsible for blood pressure, and the management of heart conditions would require multi level management, including medications and other things like good diets, staying active, and things like that. So they did say something about that in their limitation. Then they also talked about the cost of a pill for 1 month, that poly pill for 1 month to be around $26 or so. And they alluded to the fact that it might be a problem where patients are likely to pay. So, which it's very important if you're thinking about that, maybe in a setting where people would pay out of pocket, it can become a reason for non-adherence. So, take for instance, if you convert that amount to some African currencies, it's a lot of money to give out in amount for medication. That alone can dissuade people from doing what they're supposed to do because they might throw them into catastrophic spending and put them into debt. So those are some of the things. But if you look at it from maybe a health system where patients don't pay out of pocket, it might be a useful thing to do. And I think the other thing they talked about is their justification for the use of this poly pill is that sometimes the population they were talking about hardly will come back for a refill, and there were a number of issues that they noted, which is why they concentrated in people with lower socioeconomic status. So those are some of the things. But like people will always say that no study on its own is holistically complete. So you need a number of other studies to bolster any study you're talking about to make it meaningful. And that's why usually they would say systematic review would be the best option of evidence if you're looking for quantitative study and effect size. You want to do a systematic review and meta-analysis to find out. But these are some of my submission to the study.
That wants to. Sorry?
Ed.
I missed that again, Palu.
I said you should continue. I finished.
Oh, okay, fine. Yes, Kalu, thank you for that. I was asking if there was anyone else in the audience who was scrolling through the paper and are thinking about whether the results are helpful for them in the local context or just want to comment on anything. Now is your chance.
Thank you so much. It was really helpful to just listen through and go through the critical analysis. And yes, like you mentioned, one thing that struck me was that could there be an underlying inequality here? And although they tried as much as possible to ensure both arms where they removed any form of confidence, the age, their socioeconomic status, their income, and all that. So to an extent, they tried as much as possible to address that. But like you said, I was really thinking about the underlying inequality. And another thing I was concerned about was, yes, it's blinding would have been helpful, but I know it's really difficult to blind a study as this, where you have poly pills, and if the usual care are single pills, it may be difficult to really blind that study, except you get placebo in a tablet form, and you give all the to, for example, being the main and others as placebo for usual care, and maybe the others will have their may have helped, I think, because of ethical issues. Just feel what is brought me was the costs of implementing this. Yes, you said there was no cost effectiveness analysis or any economical stuff that was done to see if this can be achieved in a number of these minority group may be in this low income setting. So it's possible to really get this medication, this poly pills. But in a place where you don't have to pay out of pocket, yes, that could be applied. So I think there are a number of questions that may want to say, okay, can this be applied to the setting? But I think it's still a good research. They have good strength, and yeah, it's worth just maybe thinking about doing a systematic review to see if this is what applying in another setting. Yeah, thank you.
Hello, Zai, still there?
Point that in this case, unless you're able to make it placebo, it would be. Am I not being heard? Can you hear me?
Yes, go ahead. We can hear you.
Okay, fine. I thought I was speaking into the void. But I was saying, Emmanuel, thank you for your insight. I think, as you were saying, it would have been tricky unless they introduced a placebo to actually make it a blinded experiment. So the only way to do that would have been, or the most practical way to do that would have been to introduce a placebo. Is there anyone else that wants to say something? Even cough or anything of the kind. Let's see. All right, moving on to number 11. Would the experimental intervention provide greater value to the people in your care than any of the existing interventions? My answer was possibly. I mean, taking away from the fact that, as Carlo mentioned before, and as we've all alluded to before, that the different determinants of health, and creating a pill that doesn't necessarily address those determinants, but rather just addresses the downstream effects of those determinants, may be of use. I mean, an argument could be made that addressing social determinants could take forever or could take longer and could be more expensive than introducing a pill. However, it just seems ethically, morally strange for me. But possibly, as Black populations, even in the UK, which is where I'm based, are at a higher risk of cardiovascular disease. But once again, it is not a holistic approach, as this just addresses the biological effects of a problem that is rooted in socioeconomic factors. That was my take. I'm not going to open the floor because we already talked about this. So now going to the appraisal summary, listing key points from the critical appraisal that need to be considered when assessing the validity of the results and their usefulness in decision making. So positive for me was that it was a randomized controlled trial. So of course it weighs more in terms of evidence-based knowledge, or on the pyramid of evidence-based stuff. Clear protocol, there was very little missing data. There was good or consistent follow-up, not good follow-up, but there was consistent follow-up across the two groups. The confidence intervals and the p-values were reported. In terms of the negatives for me, was that one, it was an open label trial. Two, there was a high dropout rate in one of the study groups, which may have, which does question or cloud the validity of the results. That for me was what was negative. I'm not sure if anyone has anything else to add. Maybe someone who hasn't spoken yet. No, I can't tempt you. Anyone who hasn't spoken yet who would like to say something? Okay, back to Kalu and Emmanuel. Anything that you'd like to add?
No, nothing else. I think I've said all I wanted to say before. So
Okay. Emmanuel, anything to add on the summary?
No, I'm fine. Chief has nothing else to add, so who am I?
Oh gosh. Indeed, Emmanuel, that is very true. Just kidding.
Right.
But that is the end of this appraisal. Let me make sure that that is the end. Yep, that is the end of this appraisal. I think in summary, a lot of the methodology in this paper was sound. The data was almost complete, I should say. There was good follow-up of the participants in the sense that they were all accounted for. And the limitations are as discussed. Thank you to everyone who participated actively. Even for those listening, I hope that you learned something and took something away. At this point, I will hand over to Kalu. I think there is no need for me to ask about questions or comments as the floor has been open since the beginning. But Kalu, thank you for the opportunity to co-facilitate with you. I really enjoyed appraising this paper and I have learned a lot. Thank you, everyone.
Thank you very much, Zai, for co-facilitating with me as well. And thank you everyone that's joined in this section. Our next section would be in January, and we'll be selecting a paper for that as well. And I do welcome you to join us. I really have learned a lot as well. So each time I present or do something, I learn one thing or the other. So we might be calling on you to co-facilitate or facilitate. So depending on what it is, you might be co-facilitating with someone else. So we try to do it in such a way that the first half would be a brief summary of what it means to critique that methodology. Then the second half would be to use a relevant example to dive deep into what we've talked about in the first part. But I would like to say thank you to everyone who participated. We'll make the recording available to people so that you can listen again. And if there is any more new things you're going to learn, that will be fine as well. Thank you very much. And if there is no other thing, I would say good night to everyone and see you later. Bye.
Thank you. Bye.
Thank you.
Bye.
Bye.